Introducing the new Volvo XC90 with 7-seat versatility, Google built-in, and advanced safety features for all your precious cargo. The new Volvo XC90, designed for life. Visit volvocars.com/US to learn more.
The Jack Welch Management Institute at Strayer University helps you go from, I know the way, to I've arrived with our top 10 ranked online MBA. Gain skills you can learn today and apply tomorrow. Get ready to go from make it happen to made it happen and keep striving. Visit strayer.edu/Jack Welch MBA to learn more. Strayer University is certified to operate in Virginia by Chev and has many campuses, including at 2121 15th Street North in Arlington, Virginia.
This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME will be in the show notes. This week, we are going to be discussing what type of naltrexone is best. So how are you doing, John?
It's hot here in South Central PA. We're not used to this kind of heat wave type weather.
Yeah, it was 105 degrees in the shade on my porch yesterday when I was working from home.
Yeah, my car was like 106 or something. The one day, like all this stuff was melted in it. I mean, my beat up 11-year-old Hyundai Sonata just melted pens and stuff in it. At least it wasn't a Tesla. This is the perks of being a family doctor. We're kind of like budgeted out of that.
Doesn't matter.
Yeah.
Your car can take the heat, right? The pens might melt, but the car will still run.
Sure. My kids call it the stinky car.
Oh my gosh. Well, won't they be sad when that's the one they get to drive when they turn 16?
Yeah, definitely.
So, John, anything strike you in addiction medicine news this week?
Yes, I got like an optimistic article. This is from NPR from June 2025. It's titled Drug Deaths Plummet Among Young Americans as Fentanyl Carnage Eases. And so this is kind of basically reporting out on the most recent data about kind of drug deaths. And what they showed is that in terms of drug deaths in the fentanyl era, there's been a major drop in these. They talk about fatal drug deaths from Americans under 35 fell from 31,000 in 2021 to approximately 16,690 in 2024. So massive reduction. And I thought it was interesting that they talked about actually the biggest decline is in Generation Z. So that's the ages 20 to 29, although I feel like I always have to look at a graph as to who falls into what generation. And they saw a 47% reduction in fatal overdoses. So huge reduction for Generation Z. And teens also dropped to 40 or down 40% as well. So that was kind of a big drop in those two younger categories. So kind of like optimistic about the future. So 30 and below seems to be really kind of thriving a little bit better in today's current era. The article talks about a lot of stuff that we already know about, kind of why this is occurring, basically wider naloxone availability. Interestingly, they talk about, there's some data about patterns of drug consumption changing to a more cautious pattern post-COVID-19. Talked about shifts of opioids to safer substances. So they are kind of good or bad crediting the rise of medical marijuana and psychedelics as possibly part of the reason why, although I think that's a statement I don't know if I 100% agree with. And then interestingly, not only increased access to treatment, but also less potent fentanyl supplies in our general distribution.
Mm-hmm.
So very kind of optimistic. Some ongoing concerns. Interestingly, they still talk about a very high severity subgroup within the younger generation that really struggles with kind of illness. And also there was a slight uptick in groups born between 2005 and 2011. So there's like a subgroup in it that has a little bit more deaths. Lastly, I guess maybe to go back to our negative pessimistic attitude, they talk about kind of concerns regarding Trump administration's plan to cut $11 billion in kind of mental health and substance use treatment.
Right. Yeah, I mean, dismantling of all the sort of SAMHSA infrastructure and sort of refolding it into the Make America Healthy Again department, but under new structure and just basically cutting tons of budget, I don't imagine that's going to help overdose deaths,
Yeah, it's ironic that like the highest person in health and human services is in recovery themselves. And you think that this would be a huge moment for kind of improved services, improved access for people with a really kind of stigmatizing disease. And actually, we've gone really the opposite direction here.
Yeah. Well, and all the changes, potential changes to Medicaid, I mean, I think that's going to be the biggest problem is so many of my patients who are working full time, you know, have Medicaid and that's what provides their health care. So without the Medicaid, they're not going to be able to access care. I mean, that's just the bottom line. Um, and that'll be, I think, the biggest problem. Forget the closing of programs or, centers, even research. But if the patients can't access care, I mean, good care already exists, and if patients can't access it, then I worry we will see those deaths go up again. So yeah, that's a little bit pessimistic, but I'm really glad deaths are going down and the trend has been stable. I mean, it's been going down for a few years, not just like 1 quarter or 1 year. So it's really awesome.
Yeah, it is interesting. I mean, this is off topic, but a passion close to my heart. I think I've talked about before. I'm getting an MBA. Is kind of like a lot of times these things that we think are more expensive to do the right thing. Actually, the finances are there, and expanding access to kind of provide improved health outcomes. It really is financially viable for many of these things, including a universal payer system. I really do feel that way. And it was kind of rewarding in clinic today. I had a patient that was retiring from a career at a moderately high level in an insurance company. And the takeaway of our last visit before they switched over to Medicare was that insurance is definitely overinflated and not necessary in our current system. And they think that a universal payer is
Yeah.
warranted moving forward, which I think is ironic. They built a 35-year career off of insurance.
Well, and people talk about sort of state insurance or Medicaid or universal payer as this like evil thing, but like I don't know the facts, so I don't want to say the number, but it's something like the vast majority of Americans are actually on state insurance between Medicare, Medicaid, all the federal workers, all the state workers, all the town workers, all the veterans. Like that's actually children who get Medicaid. That's actually most Americans. It's a very, very small percentage of people who get this sort of private insurance that somehow we view as like that's what we do and everyone else is somehow scamming the system.
And the group that has private insurance, they're double paying, right?
Right.
It's
Right.
totally there.
Paying taxes for everybody else's public insurance, and then you gotta pay for your own private insurance.
Yeah, and it's interesting, that now this is getting into the finances of kind of the MBA class, but certainly a lot of the healthcare insurance models for those private insurance companies, they really favor preventive healthcare and not disease healthcare because it's really like that's why they have like incentives for mammography, colorectal cancer screening, and then if you get too sick that you can't work and you're off their insurance, you kind of go over to a state insurance for kind of
Mhm.
the expensive disease management part of it. So they kind of overly emphasize preventive care as their cost reduction strategy, but they don't really have a big intent to treat sick people.
Right. Oh, I totally see that, right, like, private insurance, they want you to go to disability, go to state insurance, turn 65, put all this stuff off until you're on Medicare. Ah,
How about you?
sigh.
What have you been reading?
Well, I just wanted to share a news update with our listeners, which is that the FDA changed the buprenorphine labeling to remove references to standard dose of 8 to 16 milligrams, which was previously being interpreted by people to mean that the maximum dose of buprenorphine was 16 milligrams a day. Um, a quote is the FDA is concerned, they say in their statement, that misrepresentation of these labeling statements may be adversely impacting patients' access to buprenorphine. So they have new recommended language for the product labeling, which is that, quote, after treatment induction to the recommended dose of equivalent 16 milligrams buprenorphine or 16 milligrams / 4 milligrams buprenorphine naloxone. So after you get to that initial induction dose per day, dosing should be further adjusted based on individual patient and clinical response. And they also did say that doses higher than 24 milligrams daily, quote, have not been investigated in randomized clinical trials, but may be appropriate in some patients. So that's actually a pretty big change because this sort of FDA labeling often drives coverage. So we're talking about insurance here. Um, I haven't had it recently because so many people are on 24 milligrams a day, but previously I would see that dose not covered by insurance. So John, in your practice, have you seen that FDA recommendation for sort of 16 milligrams being the max? Has that affected your practice? And do you think that this change in labeling will change what you do?
It's interesting. I feel like it did early in my career. I feel like there was a lot of insurance pushback for doses beyond 16 milligrams. Just like there was basically a lot of insurance cutback regarding switches over to Subutex when that was kind of standard of care for pregnancy. But I'd say like in my clinical practice in the past couple of years, I don't get a bunch of kickback for doses 16 to 24 like I used to. In full transparency, I have no one over 24 that I've taken care of. So I can't say about going higher than that, but I haven't seen an issue with that. I think it is useful. And I think over time, I was always told like physiologically when I got my X waiver and taught through that the DEAX class that no one needs more than 16 milligrams. The physiology shows the receptor saturated. Yeah, I think in clinical practice, we see that, there clearly is a group that struggles with 16 or below and actually does better on that dose. So I'm happy that, maybe it's not for everyone, but I would rather make that decision between myself and a patient than an insurance company.
Well, and we've seen that that 24 milligram dose is safe. Any study recently that's looked at which dose is best have showed that the higher doses have better outcomes and they're not unsafe. Yeah, I've gotten pushback above 24. I haven't had anyone who's chronically on 32 milligrams a day, but I've had people who are on 24, and then I tried to give PRN extra tube, like when they're undergoing a surgery and stuff, and that got blocked. But yeah, I've been okay with 24 recently, but I think it's really good because it just at least it acknowledges the reality of the dosing. Um, so, John, are you ready to talk about your article?
Sure. Yeah. So, kind of trying to mix it up. This is a really recent article from JAMA Internal Medicine in April of 2025. It's called Oral versus Extended Release Injectable Naltrexone for Hospitalized Patients with Alcohol Use Disorder. So, a little bit of background: 8% of U.S. individuals aged 12 and above meet criteria for alcohol use disorder. The lifetime prevalence is almost 1 in 3 U.S. Citizens or U.S. adults. 19% of hospital inpatients meet criteria for alcohol use disorder, but few are treated beyond kind of acute alcohol withdrawal in the hospital. 94% of patients with alcohol use disorder receive no treatment while they're in the hospital based upon previous kind of like observational study. Data shows that lack of treatment increases hospital readmissions, and we see this all the time. So, alcohol use disorder treatments include medications and psychotherapy. Often in the hospital setting, kind of definitive treatment for long-term use involves kind of referral to a more long-term or residential treatment program, not typically standard of care with medication. Naltrexone is the most commonly used medication for alcohol use disorder, and initiating treatment during hospitalization and at discharge is very feasible. It's interesting. You often learn that the injectable naltrexone is favored in this condition, and mostly looking into this data a little bit further, there's very few like large trials about this, and actually a lot of it's based upon expert opinion regarding compliance. And it's basically assumed that because there's better compliance with a monthly depot injection, that it has superior outcomes than an oral medication, which typically has moderate to poor compliance, although cost is incredibly difficult. It says $1,000, $1,064 a month versus $3,810 a month. I will tell you, I was at a meeting today about I am naltrexone buy and bill, and actually the buying price for an organization was $2,034 for one vial, so much higher than even the study was stating.
Oh my
So maybe this
gosh.
is it was hit by inflation right there with eggs and bacon.
Supply chain.
Well, cost effectiveness may be actually similar between the two when you actually consider healthcare utilization, if the one is truly more effective, especially with just how expensive hospitalization is. So, these medications do reduce hospitalization in other trials. The idea being that that price tag actually might be very cost feasible, even though it's very different if it truly has a difference in terms of preventing ED evaluations and hospitalizations. So the clinical question for this trial is, what is the comparative effectiveness of starting oral versus extended release injectable naltrexone on reducing heavy drinking among hospitalized patients with alcohol use disorder? So the study design, this is called the ADOPT study. It's the Alcohol Disorder Hospital Treatment Study. It was an open label randomized clinical trial conducted at an urban U.S. teaching hospital from June 2016 to March 2020, comparing oral naltrexone and extended release IM naltrexone in hospitalized patients with alcohol use disorder with 3 months of follow-up. Okay. It featured 248 adult inpatients, so that was age greater than 18, meeting criteria for alcohol use disorder, and they had at least one heavy drinking day in the past 30 days. Inclusion criteria was diagnosis of alcohol use disorder, one or more heavy drinking days in the 30 days prior to hospitalization. So that's 5 or more drinks in a day for men, 4 or more in a day for women. They're currently hospitalized in a general medical unit, so excluding any kind of inpatient psychiatric units. They were English speaking, and they were willing to provide contact information for at least 2 individuals to assist with follow-up. Exclusion criteria included pregnancy or breastfeeding, recent opioid use, which is a contraindication to the medication, planned opioid use after discharge or upcoming surgery, suicidality, psychosis, cognitive impairment, severe LFT abnormalities, which are defined as greater than 5 times the upper limit of normal, low platelets or coagulopathy, which would make administration a risk, body habitus, preventing intramuscular injection, naltrexone hypersensitivity, plans to leave the area within a year, so they're getting out of Dodge, or participation in another study with a medication interaction that was possible for naltrexone to interact with. So kind of a hodgepodge there. Let me kind of go through the protocol just so you understand what they were doing here, okay? So the study protocol, they basically looked for hospitalized patients with alcohol use disorder, and they were screened and enrolled in the trial. So they enrolled a total of 248 participants. When you actually look at it, while people could refer to the project, really, I think it makes a lot of sense from what we see in day-to-day clinical practice. 87.5% of these actually enrollments came from research assistants basically trolling charts. So you had research assistants going through charts in the hospital, identifying these patients and doing outreach. So once again, very similar to the common theme of treatment of alcohol use disorder in this very frequent flyer hospital population. It's not even on the clinical team's radar, as always. It was the research assistants that kind of initiated this.
Tiny caveat, are you seeing that change? I mean, you've been advocating hard for treatment of alcohol use disorder everywhere. Or I've been trying to educate all the residents. When you see someone drinking, put alcohol use disorder on the problem list and then put what you're going to do about it afterwards. But are you seeing this improving at all in our institution?
I mean, it's a work in progress. The problem too is this is a whole subject, but people in the hospital, they're way sicker than they were, at least in our area. It used to be everyone's multi specialty groups, multiple groups doing procedures, multiple simultaneous life-threatening situations requiring complex care coordination. I feel like this just isn't, it slips out of the top 10 because there's so much going on. I think there is a comfort level. There's still, of course, some stigma, but I think with time it will. I think it's just going to require us reframing this disease a little bit.
All right. It slips out of the top 10. And once you're in the hospital, theoretically, you're not drinking the alcohol. So it's actually not, not something that needs addressed in the moment. It's, although it kind of does.
And it's an uncomfortable conversation, right?
Yeah. All right. Sorry.
So anyway,
keep going.
Baseline, they got sociodemographic information. They got health status with a Charleston Comorbidity Index. They got blood work with LFTs. They did an alcohol use and severity assessment via timeline follow back and an AUD interview schedule. They did a substance use assist screening. They did an alcohol-related problems questionnaire, so that's a SIPR, a readiness to change ruler, so that 1 to 10 ruler that we love so much. They did alcohol cravings via the Penn Alcohol Craving Scale, drinking motives and reasons for quitting, and healthcare utilization via this modified Form 90. They randomized people 1-to-1 to oral naltrexone or the once-a-month extended-release injection. They stratified them by race and sex. There was concealed allocation, but there was no blinding clearly because there was no sham injections or sham pills. The intervention was daily. Naltrexone, either orally, 25 to 100 milligrams daily, and that was dispensed at discharge. Also at follow-up appointments at month 1 and 2, they were given the 1-month supply. So you didn't have to go to a pharmacy, it was given to you. Versus injectable, which is 380 milligrams daily of IM naltrexone, and that was given at discharge, the day of discharge, and then repeated at month 1 and 2. There was monthly nurse visits with medical management, and you also got your IM injection or your pill supply. And then the 3-month visit at the end of the trial really mirrored the baseline. So they did the same thing, the Charleston Comorbidity Index, LFTs. They did the timeline follow back for alcohol severity and the AUD interval schedule. They did the assist, the SIP bar, the readiness for change ruler, alcohol craving form, healthcare utilization form. The only additional thing they did is they did do alcohol biomarkers. They did a GGT, a carbohydrate deficient transferrin, and a PEth level to determine kind of objectively if people were still drinking alcohol. So the primary outcomes here were change in percent drinking days over 3 months. Secondary outcomes were any ED visit or hospitalization in 3 months. Other measures were alcohol-related nights spent in the hospital or treatment facilities, alcohol-related ED visits and outpatient visits, alcohol-related problems, medication adherence, so like oral and injectable naltrexone, healthcare costs. They did statistical analysis with intention to treat with 217 follow-ups, kind of assumed on this model to kind of adjust for kind of clinical outcomes. What do you think of this trial and what they're looking at?
I mean, I think it's a great question, direct head-to-head comparison in this very sick population who really needs help with oral versus injectable. I think my only hesitation, and this came up a little bit in our discussion of like in our live journal club, was the dosing of the oral naltrexone. Like, I think classically we've all been taught, and this is what it says in the labeling, you take 50 milligrams, 100 milligrams once a day. But in the popular culture, and I think this is probably the case, it's more effective if you take it closer to the time of drinking. And so it might have been just sort of not dosed for maximum efficacy. You would either take it at the end of the day if you drink in the afternoon, you take it targeted when drinking is sort of more likely. That might be a better way to use the oral naltrexone, and that's the way I'm seeing a lot of people using it now. That's my only complaint. So I don't know.
Yeah, so is this a valid trial? Interestingly, Alkermes did supply the drug, but they really had kind of no role in kind of study design, data collection, analysis. So it was relatively non-industry funded, but supply of medication was provided. 3 of the offers had non-financial support from pharmaceuticals. There was no other financial disclosures, so there's no signs of overt heavy industry bias here. The study was an open label RCT of 248 adult inpatients with alcohol use disorder. So, I think that this is really good for addiction medicine, right? We're not talking about this kind of massive database trial like we're often doing. This is a true RCT. I would have loved to see like a sham or placebo injection in there too. And I would have loved a control group of people that didn't receive intervention. That probably went easy to throw into the statistical analysis as well, especially when you're looking at cost of care and utilization. But overall, it was a really good study design. So I can't really kind of give any fault there. I thought it was great. I thought the study's strengths were that they looked at kind of 2 different naltrexone delivery methods, which were often kind of clinically struck between choosing. And they also had kind of like structured medical management, psychosocial support. So really, I appreciate the fact it was like a comprehensive approach. So it certainly was like a full court press treatment option here. The study population was drawn from a single urban hospital. It included a high proportion of men and unhoused individuals. This might limit generalizability. And, it's often hard when I see these more urban, like we live in a more rural area, right? I actually on the way to work, I drive past a cow pasture and through a cornfield for my like 3-mile drive to work. Although they go the other direction 3 miles, I'm in like it looks like Little Baltimore, York, Pennsylvania. Oh yeah, so I often find that these studies from these urban centers, it almost seems like a different population. I feel like my average patient, like, well, I do have many patients facing homelessness. It's not the majority of the population I serve. Certainly, I have a more kind of working substance use disorder population that tends to kind of be like, moderately to high functioning most of the time. They're able to hold a job, meet most responsibilities. Some of them have legal issues, but they're not this kind of group that's really like struggling with this many social determinants of health. So it might limit generalizability for some of the outcomes. I love the fact that the outcomes did look at like some clinically objective measures of alcohol use, but I do wonder if 3 months was probably too short to really determine something like recovery from alcohol, but also true healthcare burden of cost of disease, right? So we know that kind of disease course tends to kind of change for people throughout kind of substance use disorder. And, objectively, when you look at the end of this 3-month duration, the overall majority of people were still drinking. When you look at one of the outcomes was 75.9% of patients had elevated PEth levels, indicating an unhealthy level of still drinking. So I wonder if you took this out a year, if you would have seen something a little bit different in terms of the findings. Um, while much of the data is self-report, they did have like biochemical markers of alcohol use disorder. So I like the fact that we collaborated the two together to see whether or not there was a reporting bias. The only other thing is I've never said this before, but it would actually be interesting if they did have some insurance database data because they're looking at cost of care. If they did look, were these patients going to other hospitals? Was there other healthcare utilization? Because I think that when you kind of look at cost of care, it's more than just a medication or a hospitalization. So it's a good start to answering the question, but there could be more there going on that wasn't captured.
Mhm.
So what are the results? Interestingly, 1,503 participants were screened before enrollment. So only 17.2% of those screened were enrolled. 125 got the oral, 123 the injectable. This was a very male testosterone heavy population, 80.2%. So 199. A mean age of 49.4. 87.5% completed the 3-month follow-up. And there was really like no missing data when you like corrected for race and sex. They had relatively similar follow-up between kind of people regardless of those demographic factors. In terms of heavy drinking days, the primary outcome in the past 30 days, so how did they do the last month of the trial? Actually, surprisingly, or not surprising, but I'm happy to say actually both groups had statistically significant improvements. So both groups had large improvements. So the oral group had a 38.4% reduction. The injectable group had a 46.4% reduction. When you look at it, it's oral 27.4% experienced heavy drinking days in the days leading up to it versus 23.8% in the injectable group. When you actually look at the kind of the adjusted difference between groups, there was actually a slight difference, but it wasn't statistically significant. So both groups had similar reductions in heavy drinking days throughout the trial, which does kind of reflect natural progression of the disease in many patients.
Mhm.
In terms of secondary outcomes, hospitalization or ED visits in the prior 3 months, so the follow-up period of time frame, both had a relatively stagnant number. The oral group went from 60% to 54.1%, the injectable 61% to 61.1%. And so when you look at the odds ratio, it wasn't statistically significant in terms of difference between the two in terms of hospitalization and ED utilization. In terms of alcohol biomarkers, they just cut off PEth score of 20 nanograms per milliliter. What they showed is that both groups had very high levels of this when they obtained it. So 78.8% and 73.2% in the oral versus injectable. So 3/4 of participants were still drinking at that PEth level, which equates to like an unhealthy drinking level, which kind of correlates to that 5 drinks for a man or 4 drinks for a woman. So kind of elevated levels, or at least that's what they extrapolated there. Interestingly, and not unsurprisingly, 21.6% had elevated PEth levels despite reporting no heavy drinking days. So this does kind of reflect, I think, what we see in the general population. There's an underreporting of drinking with patients with alcohol use disorder. In terms of medication adherence, like in terms of the group that had a high medication adherence, actually, neither group was really that overly whelmingly adherent to the medication regimen. So 26.6% kind of met criteria for high medication adherence in the oral group, 40.7% in the injectable groups, showing that there was a statistically higher amount of medication adherence in people that were receiving the depot, which is kind of the theoretical mechanism for why that may be a better treatment options, or at least that's what recommendations are. Both groups had improvements in alcohol-related problems lists, that short inventory of problems, and there was no statistically significant difference between the groups. In terms of healthcare costs, when they looked at it, there was a lower cost in the oral group because there was really no difference in hospitalizations or ED visits, and the IM group was significantly more expensive in terms of injection costs. There was really no difference in serious adverse events between the two groups as well. So kind of summarizing the findings here, like the bullet points, oral versus IM, both groups were still drinking quite a bit in terms of validated biomarkers. Both groups were moderately compliant with kind of the treatment program. Both groups improved regardless of time over 3 months. And there was really no difference between the two in terms of like healthcare utilization as seen in other studies. And cost of care was higher in the IM group. So kind of a little bit different than the average discussion regarding this.
Yeah. It's interesting, John, because, when we talk about studies of opioid use disorder, a lot of the studies we've looked at recently have just looked at retention and treatment as the main primary outcome, not actual drug use, and haven't even included like objective markers of drug use. And the alcohol use disorder studies all still use heavy drinking days and these alcohol biomarkers. I haven't, some do retention and treatment, of course, but like retention and treatment was kind of low if you look at medication adherence. And yet the difference in, alcohol and heavy drinking days was a lot. Like the heavy drinking days themselves were cut down by half, I want to say, if I remember your previous slide. Like it cut out like half of alcohol use.
Yeah, actually, I would kind of disagree. I would say that they actually were a very engaged group, right? So like 87.5% of these patients completed the 3-month follow-up. They didn't take their medication as what you would consider as our classic definition of adherence, but who knows how they were taking it. Maybe they were doing it kind of as needed, or maybe they were changing how they were taking the oral frequency. I think what was interesting, the injectable group just kind of like not showing up at times for their injection. I mean, I see that all the time. It's like, I got people in like the Q7 week monthly injection, and they're just kind of coming in when they feel the need and just doing their
Right.
thing.
Which is fine if it works.
Yeah, exactly right. I'm not gonna. I mean, the article is a little perspective shaping for me. I will tell you, I feel like if my first thing with patients I talk about is that, you need to be honest with yourself. I would love you to be honest with me, but really the most important person is the person that you're looking at in the mirror, right? So if you're going to take the oral medication, I am fine prescribing you the oral medication. If you know that you're not going to take the oral medication and you want to do the IM injection because you just know you're not going to do it, that's good insight, and I'll give you the IM injection. But I don't really typically push one versus the other. I kind of have that discussion with them, and I empower them to make the decision. And I think that this just kind of continues to show that I think that this is a discussion.
Yeah, agreed. I feel like a lot of the data I've been reading recently is boosting naltrexone again. I think previously I hadn't. There have been a lot of questions about whether it was effective both for opioid and alcohol use disorder, and some of the newer data just seems like it is. It's seeming to be even more effective recently in recent studies.
I think it's hard because it's like, what is the standard of care for medications for substance use disorder? And I think that, you look at like methadone and buprenorphine, and they're just so effective at like abstinence type outcomes, more so that I think that that's what everyone kind of associates with it. So it's almost like it's guilty by association. So these medicines are effective, but if you compare them to the other ones, it's just not the same outcomes.
Mm-hmm. Agreed. Well, John, thank you so much for presenting that article. I mean, it definitely made me more confident to really let patients choose oral versus injectable. I mean, I let people choose anyway, but it gave me more confidence to say that like either one would be effective, instead of, like you said, saying, well, injection would be better. So yeah, thank you for presenting that. I did want to share some talkback comments about episode 61, which was about naloxone in pregnancy combined with buprenorphine. So we have a listener, Paramus Rad on Facebook, who said, great topic. I'd also like to hear more discussion on usefulness of naloxone regardless of pregnancy. I was surprised to learn that addition of naloxone may actually be harmful upon discontinuation, and we all know it does not completely prevent diversion or injection or inhalation, as I have learned this time and again from my patients, especially in a carceral setting. So, I think that's true. The naloxone is in the buprenorphine as abuse deterrent, which is sort of based on this stigmatizing concept that patients with addiction are going to abuse their medication, and our top priority is to prevent that abuse. And that comes out from, people's misuse of oxycodone, OxyContin, during the prescription opioid epidemic. So people did misuse it. And then naloxone sort of a holdover from that. So, I think we're kind of reevaluating that as a whole. So thank you very much for that comment. And then we got one more on the same episode on Facebook from Vanessa Lee, who said the best medication in pregnancy is usually the one that was most effective for the patient, for the pregnant patient. And I would agree with that. So thank you all for writing in. If anyone else has any comments about any of our articles, we would love to hear from you. We really think the best part of any journal club is the conversation between the people in the journal club, and we really want to hear what you have to say. So we have all the social medias you can send us comments on, and Spotify has a feature for those of you who listen on Spotify. You can leave comments directly on the episode on Spotify, and we will get those as well. All the links will be in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.
Navigating a SOC 2 audit can be overwhelming, but Framework Security's automated process makes it simple. Our experts guide you through streamlined prep with clear steps and real support. No fluff, no wasted time. We help you avoid common pitfalls and get across the finish line with confidence. Click the link to learn more about how we make automated SOC 2 compliance easier.